Hello everyone, it's Yunshan from Gansu Provincial Hospital. It's my great honor to be here to share our experience in pulmonary hypertension caused by fibrosing mediastinitis. As you know, fibrosing mediastinitis is characterized by proliferative fibrotic tissue comprising pulmonary artery, pulmonary vein, and the bronchus, which can lead to pulmonary hypertension and right heart failure. Fibrosing mediastinitis caused pulmonary hypertension belongs to group 5 pulmonary hypertension. As the imaging showed, we can see the dotted yellow line is the proliferative fibrotic tissues, which comprise the pulmonary artery and the pulmonary vein. Till now, only one study reported the survival rate of pulmonary hypertension induced by fibrosing mediastinitis. This study only included 27 patients. The 5-year survival rate is about 56%. From our registered study, we included 369 patients. The 5-year survival rate is 74%. It's still unknown about the precise mechanisms of fibrosing mediastinitis. We know some triggers include TB, histoplasm, idiopathic, which can stimulate abnormal immune response. The common symptoms is dyspnea, cough, and refractory hemoptysis, pleural effusion. The symptoms of fibrosing mediastinitis is related to affected anatomic structures. For example, pulmonary artery involvement can lead to pulmonary hypertension, severe hemoptysis due to bronchial artery collaterals. For pulmonary vein involvement, which can lead to pulmonary hypertension, pleural effusion, and mild to moderate hemoptysis due to pulmonary venous congestion. For bronchial compression, which can lead to cough, dyspnea, and atelectasis. Atelectasis is very specific for screening fibrosing mediastinitis. Also, in some patients, we can see superior venous cava syndrome due to superior vena cava compression. It's very common for fibrosing mediastinitis to be under diagnosis, but we know some imaging clue which is useful to screen fibrosing mediastinitis caused pulmonary hypertension. We call the fibrosing mediastinitis dyad and the fibrosing mediastinitis triad. We can see this image. So predominant main pulmonary artery and atelectasis called fibrosing mediastinitis dyad. Dyad plus pleural effusion we call the FM triad. And also mismatch the perfusion defects indicate obstructive pulmonary vascular disease beyond the pulmonary embolism. For electrocardiogram, the PASS syndrome is useful to screen fibrosing mediastinitis. among the adult. We can see the flattened or inverted T wave in precordial leads, plus increased S wave in lead 1 and increased R wave in AVR lead. Here is a patient's chest X-ray. We can see pH sign and atelectasis and pleuroeffusion. So it's a typical FM triad. CTPV showed the pulmonary vein is severe stenosis. We also can see the interlobular septum thickness, indicating pulmonary vein stenosis. For VQ scan, we can see the mismatched perfusion defects with normal ventilation. According to our previous study, atelectasis, pleuroeffusion, and some clinical features have 91% sensitivity and 83% specificity to diagnose PH-FM from PH non-FM. Here is an example of electrocardiogram of fibrosing mediastinitis-induced pulmonary hypertension. We can see the precordial leads, T wave in precordial leads is flattened or inverted. So after standing, we can see the T wave recovered. This picture is helpful to understand the changes of electrocardiogram of FM. We can see pre-stand and post-stand. We can see the enlarged right heart induced the changes of electrocardiogram. And when the right heart recovered, the ECG also recovered partially. Here is the typical CT and MRI of fibrosing mediastinitis. We can see the proliferative fibrotic tissues around the mediastinum, compressing pulmonary artery and the pulmonary vein and the bronchus. So the star showed atelectasis. So the MRI also showed the same sign. Here is a PET. We can see the abnormal FDG intake. And the pathology study showed CD3 positive T cell and CD20 positive B cell increased. This slide is explain why the PWP is not increased in FM patient, because the stenotic pulmonary vein located at the proximal of first branch of pulmonary vein, but not the ostimal. Because you know the balloon of Swan-Ganz is 13 millimeters. So if the pulmonary vein is greater than the balloon diameter, the PWP should be increased. If the stenotic site is less than 13 millimeters, the PWP should not increase. The most important thing is about classification of FM. We call it type 1, type 2, type 3. Type 1 is only involved in pulmonary artery. Pulmonary vein involvement we call the type 2. For type 3, both pulmonary artery and the pulmonary vein involved. For diagnostic flow, it's useful to reference pulmonary hypertension guideline. Most important thing is to identify stenotic pulmonary vessel disease from general pulmonary hypertension. If patient with FM diode and FM triad and refractory pleural effusion and unexplained hemoptysis or SVC syndrome, so fibrosing mediastinitis is suspected. Furthermore, CTPA plus CTPV should be performed. Most important thing for diagnosis is classification, which is useful to make a plan of interventional strategy. Treatment. Till now, no effective drugs to treat fibrosing mediastinitis. Also, the surgery is high risk with 20% mortality. So, the first choice is endovascular therapy. Previous study, even small sample size, showed effective and safety. Here is the pulmonary vein flow grid, which is proposed by our team. I think it's useful to evaluate the effect of interventional treatment for pulmonary vein. The pulmonary vein angiography is retrograde. So for the grade 3, the contrast is rapidly back to the atria. If the contrast cannot have no pulsatile phenomenon, we call the grade 0. So if the distal pulmonary vein is very clearly indicating severe stenotic at the proximal pulmonary vein. We also proposed the nomenclature of branch pulmonary vein, which is helpful for communication of interventional cardiologists. Here is an example of percutaneous pulmonary artery angioplasty. We can see pre-standing the stenotic pulmonary artery is very severe, and standing after stent, we can see the pulmonary artery, the lumen recovered. Here is a percutaneous pulmonary vein angioplasty. So pre-standing, we can see the proximal pulmonary vein is very severe stenotic, so standing after stand, the pulmonary vein patents recovered. So we summarized our previous data from 2018 to 2019. Only 59 sessions, 35 patients included 43 arteries and 53 veins. The follow-up time is not very long, it's very short. So we can see the immediate effects is significant, include the pulmonary vein diameter improvement, pulmonary vein flow rate improvement, and the pressure gradient decreased, both pulmonary vein and the pulmonary artery lesions. Now we have much more fibrosing mediastinitis cases. So we are summarizing the data. I think in the near future we can share and report our results. So here is about hemodynamic improvement and exercise capacity improvement. Complications. Hemoptysis is the most common complications for pulmonary vessel intervention. Because it's totally different from systemic circulation. So according to the features of pulmonary vessels and for pulmonary vessel stenosis, which contributed to different etiologies. Different etiologies have different pathological characteristics, so which need different interventional tips. Now we refined the procedure. After refining the procedure, the hemodynamic rate is very lower than before. So we also summarizing this refined procedure. I think in the near future we can share with us. Let's, for example, female, 57 years old, exertional discipline 5 years, and hemoptysis 20 hours. Echo showed the pulmonary hypertension. So first we performed the VQ scan, showed mismatched perfusion defects. The CT showed pulmonary hypertension caused by fibrosing mediastinitis type 3, pulmonary artery and pulmonary vein stenosis. So first session we treated the right pulmonary vein, and 3 months later there are restenosis in pulmonary vein stent. Also, we planned to treat pulmonary artery stenosis. So first we treated the restenosis in pulmonary vein, and meantime we treated the pulmonary artery. Here is a bifurcation lesions. So we use kissing technique. Here is the follow-up. We can see the hyperplasia in the pulmonary artery stent. But for pulmonary artery stent, the risk stenosis is low, about 5%. For pulmonary vein, the risk stenosis rate is very high, as 50% during half-year follow-up. For the intervention tips, we summarized the 5 steps. Evaluation, PA, PV, bronchus, parenchymal. All of these features need to be evaluated carefully. Then classification, type 1, type 2, type 3. For the treatment sequence is PV first. For the strategy, lower pressure dilation is preferred. So we call the half-half. And we need to pay more attention to cough, which is a warning of complication. Take-home messages is FM diet, FM tried, and classification. So we can use this imaging clue to find more FM patients. I think it's very important for early diagnosis. Also, we have lots of unsolved problems. Thank you.